Right. Thank you, Susan. So good afternoon, everybody. It's a pleasure to welcome, to introduce Jonathan. Welcome him, I guess, ensconced in his apartment in Toronto. So Jonathan's a postdoc fellow, did a PhD at UBC, and previous to that, did training in Toronto. He's a FRQS funded postdoc here with us, working with myself and Kevin quite a bit on TB, but since March, as with many groups, he and others of the team have been working actively on things for COVID. And so some of this work he will present now. So I'll turn it over to you, Jonathan. I would also, maybe Susan already mentioned this, just everybody mute to make sure all the kinds of background noise doesn't come in.
All right, thanks, Dick. As Dick said, we began back in March kind of passively looking at COVID, and then as things kind of ramped up, we started actively looking at it, which kind of led to our title here, where we're looking at kind of active testing strategies for SARS-CoV-2 and how they might complement current measures to contain COVID-19. So I'll talk to you about how that can help kind of unblind us about things here. Just brief disclosures, this was funded by MI4 as part of their round 1 grants, and I've kind of just done a bit of work for some other organizations on COVID-19 too. So there's no secret here to kind of say that COVID-19 is truly global. Really no place has been spared. You can see our neighbors to the south. There's really no land, it seems, where there's no big red dots signifying a significant amount of cases. As of yesterday, there was nearly 38 million cases of COVID-19 confirmed. We all know that those are pretty strong underestimates. Estimates probably 5 to 20 times higher than that. And over 1 million recorded deaths. And again, we know that's probably also an underestimate. Just recently published some data on that excess mortality. So really, it's a dire situation. COVID's gone everywhere. And to say the least, the strategies for containment have been quite varied country to country and largely passive. And the World Bank has predicted some pretty serious economic repercussions because of COVID, significant lockdown measures that went in, the global recession that ensued in March. And this is clearly affecting pretty much the whole world, except for, it looks like, East Asia and the Pacific, where control of COVID-19 has been markedly better. You can see that the hardest hit region is Latin America and the Caribbean, the current epicenter. And a lot of these places that are hard hit, there's already large inequalities in income, and it's threatening to push millions more into poverty. So a lot of economic gains made over the past decade. I wouldn't say threatened. I mean, they are gonna be pulled, it's gonna pull back. So just briefly, some of the drivers of the pandemic, at least early on, and probably continuing to today. The severity of COVID-19 really varies. It's got a wide presentation. People can be completely asymptomatic throughout infection. It's about 1/3 of people completely asymptomatic, to people who are extremely ill, require hospitalization, intensive care, and eventually death. And this wide varying presentation makes it difficult to detect. It's not, people who are infectious aren't immediately obvious. The diagnostics early on were at least not widely available, and a lot of the materials required to collect samples for them were in short supply. The infrastructure in much of the world wasn't in place, so it became very difficult to diagnose, and with the primary mechanism of diagnosis via RT-PCR, that's no surprise. And then this is true in a lot of low middle income countries, but really Canada, the US, high income countries are no exception. There's large inequalities in income, living conditions, flexibility of employment, and access to healthcare services. This is kind of, COVID-19 has magnified this inequality. And because of these inequalities, it's difficult for everyone to follow public health measures as closely as you would like. Initially, we might have started with this goal of eradication, kind of bringing case numbers down to 0. But I think that's pretty clear to most of the world, except for maybe parts of Oceania, that is going to be unlikely for some time. One of the kind of big reasons for this right now is that population self-monitoring is not possible. We don't have any rapid and expensive self-administered daily tests. These rapid antigen-based tests are not the answer. They're really approved for symptomatic diagnosis and not really for population-based monitoring. And really, if we ever get a test like this, it's going to be quite a while before they can be produced in the numbers we need and as accessible as we would want. And yet there's no vaccine available right now. Of course, there's hope for the new year, but there's already, vaccines aren't going to be going to everyone. There's going to be prioritization. We don't know what real world effectiveness is. So it's not going to be the silver bullet. It's just going to be one more kind of piece of the armamentarium right now we have against COVID-19. So our strategy moving forward is really focused on containment rather than eradication. The problem with this is that we're flying blind in many parts of the world. The extent of dynamics of COVID-19 remain largely unknown, which populations are being most effective, where it's circulating in the community. And this means that current methods are going to be inadequate to control COVID-19. And this is in large part due to because testing is largely passive. Right? Passive testing, when I say that, I'm talking about testing that occurs that uses resources or events that would occur without any additional intervention. So in cases, for example, where testing is performed, the onus to present is on the person presenting. So clinically presenting cases, people going to self-assessment centers, these are passive testing measures. We're not going out and looking for people to test. And so we want to try and think of how we can better control COVID-19. And initially, we saw this impending uptick in cases, this curve getting steeper and steeper, cases rising and rising, and we had to catch up. And what we did was we implemented pretty strict lockdown measures in many jurisdictions. And it became pretty abundantly clear that these are short-term solutions, they're not long-term. And definitely not sustainable over time because of the adverse economic and social impacts in populations subjected to these measures. So moving forward, probably what we should have been thinking about in May was to try and get ahead of the curve, which means that we should probably consider widening who is tested, where, and how often to better inform public health strategies so that when the second wave, which feels like it's definitely already upon us, we could get ahead of it and crush it before it took over. The reason we need to get active is kind of goes to the issues of passive testing approaches, right? I'll come back that severity of disease is variable and severe clinical disease is a minority of all COVID-19. We know our testing systems right now cannot handle everyone that's showing up. People with not everybody with symptoms are going to go to these assessment centers. The people with milder disease are generally younger, and they're the ones who are likely to have a large number of contacts. And importantly, the age of everybody with COVID-19 is dropping. So undetected spread may occur if you're relying on this passive presentation. And of course, there's been many documented cases of asymptomatic or pre-symptomatic transmission. I can't quite remember where it is. I think it was in Ontario, a massive super spreader event at a spin club where a person asymptomatic at the time has now led to 51 new infections. So this widely variable presentation makes it difficult to detect, and passive approaches really aren't going to get us under control. So we wanted to advocate for an approach to testing that is more active. Of course, this requires additional resources to collect data or the samples necessary to perform testing. And it relies on the healthcare system to work to collect these samples. And one of these a pillar of any strategy is active testing of contacts. So that goes through contact tracing and subsequent testing. The major advantage here is that the purposes of surveillance, it really gives you data above and beyond what can be gathered by any and all passive approaches. And it permits data-driven tailoring of responses to the pandemic by giving a more complete picture of what is going on in the populations who we are targeting for active testing. And I'd like to argue here that it's not maybe typically thought of as a non-pharmaceutical intervention, but it is the most important non-pharmaceutical intervention that we have right now. We have several, right, with few therapeutic options and without a vaccine. Really, we're relying on non-pharmaceutical interventions like masking, hand hygiene, distancing, closing certain businesses and areas, and infection control measures. But testing is one of these underutilized and a very important method to assess the effectiveness of these measures and provide the necessary data to tailor their intensity and targeting. So really it is a tool to direct the rest of your NPIs, and I think it's very underutilized. Can provide data on which populations are being affected, where they're being affected, how they could be being affected, and depending on the types of tests you're using, when they're being affected. Okay, and I had this nice graphic made for me actually. But without an active approach, you can see that really there's a lot of non-specific broad measures for many populations. You can see that we're targeted regionally in Quebec right now with measures. In Ontario, the same. Early on, it was broad, non-specific. Everyone was subjected to the same. With an active approach where you're going around and collecting data on certain populations, you can make specific measures tailored to those groups. You can see early on, we were in this big uptick in Canada, and there was this nice little nadir, I guess, where cases slowed down. And this would have been the perfect time to start thinking about how we are going to implement active testing, how we're going to go and strengthen our testing systems to prepare for the impending wave in the fall. And it seems like, at least from some reports I've read in Ontario, that was simply too expensive, too logistically challenging. And you can see the uptick going on now in many parts of Canada. And unfortunately, there's a lot of people paying the price. Not saying it's the only reason. Testing isn't just the thing that's going to solve everything, but it can certainly help. So we asked ourselves back in, say, when we started working on this in March and through April and May for the majority of our work, is how we might better utilize testing in Canada. So of course, there's many tests now available for COVID-19 or SARS-CoV-2, and they all have a role to play in expanded testing, right? You have tests for acute or current infection, so how COVID-19 is affecting people or populations now. As I mentioned before, we have the RT-PCR, and now some rapid antigen-based point-of-care tests, where you just take a little lower nasal swab and you can get a result back. Of course, those are only suitable for symptomatic people. These tests for current infection can inform both reactive measures and proactive measures. Right? If it's used once, you can provide data on changes in epidemiology. So you can look at particularly affected populations right now. And if you repeat these tests, that can inform modeling. So it can help predict how COVID-19 might change in the future and inform proactive measures to get ahead of that impending curve, should the model predict that. And it can also be used to demonstrate how mitigation measures are working. So if you saw cases were high early on, you implemented mitigation measures, you come back, you perform this testing again, you can see if those were adequate to quell the spread. Do you need to go again and reinforce or retarget these measures? And then you have tests for previous infection. Right now, these are the immunoassays or antibody tests. And these both also can inform reactive and proactive measures. Reactive, it can provide data on how current mitigation strategies have worked to protect populations. If you have sampled a representative group in a population, you know what you've been doing to protect them. If seroprevalence is high, that might indicate that what you were doing in the past has not been effective, so you can go and reinforce or rethink your strategies. And they can also be proactive. If you're looking at areas in Quebec that were spared, for example, from the first wave, you can use areas that were hit to see who had been hardest hit, where the virus kind of centralized, and you can use that to implement proactive measures in these unhit areas in impending second waves, so you know where populations will be at risk. So really, we have a good armamentarium of tests available. I'm not going to go over these rapid antigen-based tests because they're really for symptomatic testing. They're not suitable to be used in asymptomatic persons. If anyone's familiar with White House outbreak, these are the kind of tests they were using. Clearly, it's one example, but really subpar sensitivity in asymptomatic persons. And I'm not going to go over antibody tests in this presentation, but just know that they're very useful as surveillance tools. I spoke to them about reactive and proactive measures. They're also very key when vaccines get rolled out. So they definitely will have a role to play. So for this talk, I'm going to be talking about RT-PCR and its role in expanded testing. So when we started thinking about who we wanted to target, early on, we knew symptomatic individuals were prioritized. These are clearly people most likely to infect others. They're also the minority of the Canadian population. We thought of this pyramid here, where at the top of the pyramid, you had the risk, so increasing prevalence, let's say, of SARS-CoV-2. And based on this risk, risk kind of congregate in smaller groups. You would have smaller populations towards the top of the pyramid. We wanted to go think our way down in terms of different areas in Canada or population groups where you would want to go and focus beyond these symptomatic individuals. And the obvious choice up front were, of course, close contacts of people with confirmed COVID-19. And really, this is key to break chains of transmission. So you get in early. Okay, people, if you're not contact tracing, people won't know they're being exposed. If they're not being tested, they're unlikely to be engaged with the healthcare system. They might not always adhere with isolation. It's always good to know who's positive, who's negative. This also provides important epidemiological data. Okay, but where do we go beyond these groups? And we thought, there are vulnerable populations, right? There are people, they're the elderly, those in congregate settings. There are geographic transmission hotspots. There are key economic sectors which vary province to province. And if you wanted to try and keep jobs and economies protected, you might think about prioritizing them. There's high-risk employment sectors. The most obvious are healthcare workers. But then there's also other jobs that put people into repeated contact, either with their own coworkers, the public, or both. And really, these people are at high risk of being exposed and never knowing it. And outbreaks can lead to shuttering, can obviously lead to shuttering of these businesses. And then there's schools, which, depending on class sizes, non-pharmaceutical interventions in place, they may form a high-risk environment for close contact. We know that the virus moves from younger age groups to older age groups, so this can lead to spread outside of the school. So working through this, we conceptualized some, firm groups. Right? There's variable economic sectors, so we didn't want to focus on that. Vulnerable populations are variable. We didn't want to focus on that. So we wanted to look at groups that we could define and look into a bit closer. So we looked at staff in hospitals, so specifically acute care hospitals, largely dealing with COVID-19 are at high risk of exposure. So we think they're a key group that we would be thinking about and prioritizing them quite high on the pyramid. The next we looked at were community healthcare workers and people in long-term care facilities. So that's both staff and residents. I don't need to belabor this point. I think anyone who's been reading the news the last 6 months knows about some of the devastating outbreaks in there. And then we went down and said there were essential workers at high risk of contact with coworkers, the public, or both, who would be next in line in terms of priority. And then you have people in schools. And so the idea here in this pyramid is you work down the pyramid based on your testing capacity. If you don't have capacity for contacts, you should be focusing on symptomatic individuals. Once capacity, you should be working to build capacity to reach contacts. Once you can cover those groups, you should be working to get down into hospitals, community healthcare workers, etc. It's really a reasoned kind of thought out approach to how we would be prioritizing limited testing resources. I'm going to advocate here that all people in these top two groups should be tested. These aren't really for surveillance purposes at all. The intent of testing is diagnostic. Okay, and the groups below might not always be diagnostic in intent, could be for surveillance purposes. So really, testing will depend on priorities. So we asked ourselves, if we wanted to go and expand testing to these groups, what sort of resources would be required to test these populations? And so we gathered some key epidemiologic and testing information across these groups. We looked at the number of assessment centers in each of the 10 Canadian provinces. There were no cases currently in the time of writing in July in the territory, so we hadn't considered them. We looked at the provincial laboratory capacity at the time, and then the population size of each of the groups that we wanted to test. We conceptualized testing as a 6-stage framework, which began with scheduling the people in each of these groups that you wanted to test, collecting the samples for RT-PCR analysis. In this first analysis, we're going to think of sampling as being performed with nasopharyngeal swabs. And then, of course, the transportation of these samples to the laboratory where it would be analyzed, then communicated to public health authorities who would refer the results to the people who were sampled. And then there's acting on results. So this really focuses on the contact tracing and testing among people who are positive. So for resource estimation, we looked at the costs associated with each of those individual stages and the human resource requirements. So who would be needed to schedule people at assessment centers? Who would be needed to go and collect these samples? So work in these assessment centers, you're thinking not only just healthcare workers, there's security, there's administrative and clerical personnel. At the labs, there's laboratory personnel, there's transportation attendants or drivers to go and ship these samples to the labs. Really looked at the whole array of human resource requirements across each stage, and the costs associated with their salary as well, and the materials required. So we spoke with several laboratory experts and public health officials in Montreal to really try and build this framework up and how we would conceptualize it. So what occurs at sampling centers, what happens when samples get to the lab and they go through an analysis, when results get back to public health, what happens, and then what's the process for contact tracing. And early on, when we were very, very overwhelmed, we'd heard that contact tracing there was no testing really, right? It was contact tracing, and they were only reaching about 5 contacts per person who had tested positive, and recommending contacts isolate. Later on, as cases died down, contact tracing, you could begin testing contacts, but now as we're overwhelmed, we've seen several news reports of how contact tracing and testing systems have been overwhelmed, and it almost feels like we're back in March with where we're at. So because we were looking at nasopharyngeal swab sample collection, we assumed that everything was being performed by trained healthcare professionals. So obviously a high human resource cost for sample collection. And we considered, as I mentioned above, the personnel time, transportation, and materials needed. but we didn't consider costs or human resources necessary for kind of building additional infrastructure, capacity scale up, human resource training associated here. We just wanted to know how many people are we going to need, and then we can plan on how we're going to get there. And what are going to be the costs at the end of the day? So starting with our highest priority group, the costs associated with tracing and testing of contacts. So we'd done this back in July. Positivity was actually a third of what it is now, and we were only doing about 45,000 tests. So I've updated the analysis for this presentation to where we're at as of today, which is 77,000 tests done on average per day with an overall positivity of 2.4%. And this means that about every day, we're going to have 1,850 people testing positive who should have their contacts traced and tested. Statistics Canada estimates that the average household size in Canada is about 3 people. So you can expect that each of these people who have COVID, who are diagnosed, might have on average about 2 additional household contacts. And then based on earlier reports in March when there was kind of no lockdown, and really based on the behavior of maybe not the whole population, but kind of we've all got relaxed over the summer and maybe still are, we assume that there would be about 14 non-household contacts per person. So that led to us assuming there were going to be 16 contacts that had to be traced and tested. And using the literature, we assume that people in the household, there was about 15% that would be positive, and out those 14 contacts outside the household, about 1% would be infected. And if you do the math here, over 4 weeks, this means that we're looking at 825,000 contacts that have to be traced and tested. When I kind of went back to where we were in July, we were at a quarter of this number. So we really only, in July, there was only going to be 200,000 contacts to trace and test. Feels like we're, what, 2 months later, 3 months later, and it's quadrupled. So really, the epidemiology has changed incredibly fast in Canada, and it's kind of becomes evident why we're overwhelmed now. So this is what we found in our analysis. So we looked down those 6 stages of the framework, and we looked at, okay, if we wanted to go and test 825,000 contacts over 28 days, how many people are we going to need each day to make sure that we can schedule them, bring them to an assessment center, collect their samples, ship them to the lab, get those samples analyzed, communicate the results, and then perform additional contact tracing. And here you can see we need about 5,300 personnel, and that's split heavily into administrative personnel that are involved heavily in contact tracing, but also in scheduling and a lot of the data collection at assessment centers, and a lot of the communication results back to people who are tested. You have a high number of healthcare professionals needed to do the sample collection, and of course laboratory personnel to do the analysis. But still, it's only 30,000 samples per day to test all contacts. When you're looking at probably we'd estimated in July, the Canadian laboratory capacity was about 100,000 tests per day, and that's since expanded in many provinces. I definitely think it's well above 125,000 tests per day. And if we're only testing 77,000 people, we definitely already have the laboratory capacity to test these additional 30,000 or so. Of course, I'm not trying to gloss over the issues of reagent shortages and of course just getting the personnel involved to do this testing. But really, we do have the capacity, and the costs are 2.1 million per day to test these people, to test contacts. When you look over every 28 days, that's about $60 million associated with contact tracing and testing. I won't belabor the point too much, but when the economic response in Canada to try to address COVID-19 was about $169 billion as of the middle of June. I just checked before this presentation. They haven't updated it because I'm sure they haven't considered what the costs going forward are going to be with the new Canada recovery benefits. But people on CERB alone we're costing about 15 billion a month. So in comparison, 60 million to fund tracing and testing of contacts is minimal. Okay, and a couple notes there just for caveats of this analysis. As I mentioned before, the other risk groups, so the people in healthcare settings, other essential businesses, and in schools, really testing of everyone is unlikely to be immediately feasible. Right? These groups represent large numbers. There's over 6 million staff and school children in elementary and secondary schools alone, and over 4 million people that work in acute care hospitals who work or live in long-term care or who work in essential businesses. So right now, the most realistic thing and the kind of analysis I'm going to focus on for this talk is surveillance testing of these groups, where only a representative sample of the population is tested. And this can be obviously used to gather data to make decisions on intervention. So where additional testing might be needed, where additional mitigation measures might be required, or where further investigation is needed to figure out exactly what's going on. And this is much less costly and human resource intensive than testing 10 million people. So for this analysis, we looked at what would be the cost and human resource needs if we were going to go and conduct this surveillance testing over 2-week intervals in randomly selected groups, selected samples from each of these groups. Just one second, I've been talking a lot today, so I just need to take a sip of water. Right, so we assumed all testing would be conducted on site by mobile teams. So this is different from the contact tracing and testing where we referred people to assessment centers. It's really inconvenient for people to go to these assessment centers for testing. So we thought that the best way to ensure uptake and acceptance of testing and really to get good coverage would be to bring testing to people. And these mobile teams would organize areas for testing, collect samples, and then drop them off at laboratories. So of course, there's a large coordination component with this, and we of course considered that in our cost and resource needs. So this is a busy table. This is where we were at in the middle of July in terms of estimated prevalence. I'd hazard a guess we're 2 to 4 times higher now. The good thing about surveillance testing, which I mentioned at the bottom here, is that actually as your estimated prevalence increases, the sample size to accurately estimate that drops. But if you kind of are adjusting your relative precision, which means your confidence around your estimate, the sample sizes actually tend to be pretty consistent. So if we were to triple the estimated prevalence and reduce our relative precision, so that our estimate is not going 100% more than our estimated prevalence to 100% less, the population to sample is quite similar. So these costs, I think, are quite representative for surveillance testing at large in these groups. So over 14 days at the bottom, you see there's about 410,000 people to sample. So out of 10 million people, we'd be testing 4%. Pausing there, just checking my math. You guys can correct me in the chat if I'm wrong, but about 4% of the population overall would be targeted for surveillance testing. Of course, significant increase in the number of healthcare and administrative personnel required, largely because we conceptualized this as 2-person mobile teams, one administrative personnel to collect data and on people who are being sampled in a healthcare professional to administer the nasopharyngeal swab. But only 34,000 tests per day would be required in terms of national laboratory capacity. Again, very modest, I'd say probably doable. And the cost, again, 69 million every 2 weeks, $140 million every month. Really, really modest when we start thinking about costs associated with CERB and other economic implications of COVID-19. And if this is a method that can allow people to safely return to work, it can allow us to get ahead of outbreaks, it can protect population health, it is a fantastic investment. So the repetition of surveillance testing, of course, if the point is to go and determine what is going on in populations, it will need to be repeated. Based on the findings, you will then implement additional measures. You might retarget them, remove them, etc. The thing is, you can't make evidence-based decisions without evidence, and that's what surveillance testing is informed to give. If you wanted to do this for modeling, right, this is what they do. This is the UK Infection Survey, does something very similar to this. Every 14 days, they have reports on what is going on in the community. It started in England. They've now expanded to Wales and Northern Ireland. They're trying to get kind of a full country picture of what's going on, and they actually have modeling data that they report on, and they can look at what's going on regionally, what's going on, what might be happening in the future. And it can also then, as I said, really allow us to assess impacts of implemented measures and permits continual evaluation of these measures, and can augment testing data that we collect from passive presentation. The frequency of when you want to repeat it will vary. I proposed on the last slide that we do it, you know, it's a continual thing. Every 2 weeks, you're going out to test 4% of these populations, and you keep going over and over again. But if prevalence is low, you might not need to be doing it that often. But if the intent of this sort of testing is to detect or prevent outbreaks before symptomatic detection would, so let's say we're talking about systematic testing of healthcare workers in certain long-term care facilities, which I'd seen, I'm not sure how fully implemented it is now, but there was a plan based on incidents in different regions in Montreal to test healthcare workers in long-term care either twice a week, every 2 weeks, etc., which seemed to be evidence-based on the initial circulating prevalence in the setting and community prevalence. So of course, if it's low, it can be more infrequent. If it's high, you would want to increase the frequency of testing among these groups. So there's real value in surveillance testing, and in particular in repeating surveillance testing in terms of a comprehensive public health response to COVID-19. So for the last section of this talk, I wanted to go into one technique that we looked at in great detail that could reduce human resource demand and help save money, and that's saliva sampling. All the estimates you saw previously were using nasopharyngeal sampling. And saliva has a lot of practical advantages in comparison. Nasopharyngeal swabs can be very uncomfortable. We had received an email from somebody who's looking at saliva sampling in a healthcare setting, and the Quebec government, or the Montreal Public Health, whoever had released the document, I can't quite remember, when they were talking about frequency of testing in long-term care settings, they'd assumed uptake of 60% among staff for these repeat swabs. This person who'd reached out about saliva sampling had reported 20% uptake for repeat testing with swabs. So it's not really an anecdote that they're uncomfortable. It has real impact on test uptake. The swabs in the past and their transport media that they are stored in during transportation to the lab have been in short supply, creating a bottleneck which limited the number of people who could be tested. As I emphasized earlier, required trained healthcare professional to administer and requires extensive PPE. You're getting up close and personal with someone, sticking a 6-inch plus swab down their nasal cavity. You need to be in proper facial protection, gowned up, gloves, surgical mask, face shield, etc. And it can be time consuming to collect. While saliva sampling overcomes these issues, at least in part in some aspects, and removes some of the HR material bottlenecks. For the majority of people, production of saliva is possible. for another fraction of the population that can produce saliva, there's now this saline swish and gargle approach. So basically, if you don't have saliva, we'll provide you with something to collect a sample. Depending on which approach you're going to go with, it can only require a sterile cup.
Yeah. So they need.
I'm getting feedback from someone.
Yes.
Anyway, depending on, yeah, so it only requires a sterile cup or saline. So you don't need the swabs, you don't need the transport media. It can be self-collected after verbal instruction, and almost anyone can provide this guidance. So you don't need the trained healthcare professional to collect it. You create simple graphics that explain how to put the saline in your mouth, swish, gargle, place it back in the tube and close it. It can be verbally instructed if they're just going to spit in a cup and produce up to 5 mils of saliva, however much you need. So really, because collection's contact free, you don't need eye protection and gowns. You need surgical mask and gloves. And it can be collected in less time than swabs because you're also saving the time associated with changing gowns and gloves between each person. Gloves you still change, but the gown is a bit more time consuming to change. So the question has been always about sensitivity. Right, saliva samples collected in saline require minimal pre-analytical work, can be analyzed the same way as NP swabs. Raw saliva, if it's too viscous, may require a bit more pre-analytical work for analysis. The key here is when we're talking about saliva samples, we're not talking about a new technology out here. We're talking about just a different sample being analyzed the same way as swabs. So we don't need Health Canada approval, but we need laboratory validation to make sure that our lab processes are getting us the results we expect. This was done in Quebec, it's been done in BC and Ontario. So really it simplifies the process for adoption. But one of the major concerns here has always been the uncertainty regarding sensitivity, which I think at least in Quebec and BC, Ontario, where it's being adopted, has been addressed. But I'll kind of go over some of the data that we found as well. Where we conducted a meta-analysis to look at the difference in sensitivity of saliva versus nasopharyngeal sampling to detect SARS-CoV-2. So we did this recent August 10th. I believe kind of all these reports out of saliva sampling being adopted in Canada came out September-ish. And we included studies that included 5 paired NP swab and saliva samples collected from at least 5 different people, paired sample collection. And we performed the primary outcome we were looking at was the difference in sensitivity between NP swabs and saliva with a reference standard of positive on either samples, because we're not expecting false positives to come out of here. So if it's detected in saliva, not on swabs, I really don't, it's very unlikely it's a false positive. Ditto in the other direction. So positive on either sample was our reference standard. And then we conducted several stratified analyses to see what, if there's any factors that could be affecting this difference in sensitivity. So looking at symptoms present at testing, the reason for testing, and the saliva collection method. Briefly, we found, here's the Prisma diagram, we found 20 studies describing 22 unique cohorts at the end of the day. When we'd done this back in May, there was like 3 studies, so we were quite actually happy to find this. And I'll spoil it at the top. There's no significant difference in sensitivity if you've read BC reports. I don't know if LSBQ has published theirs, but there's no significant difference in sensitivity here. So we had 19 cohorts that used lab-based RT-PCR on over 2,300 paired samples, and actually saliva had non-significant, 2.9% higher sensitivity than nasopharyngeal swabs in our stratified analyses. We did notice there were differences in the direction of effect, but results never became significant. Among persons who were presenting for SARS-CoV-2 testing, such as those who go to assessment centers, people where we have unconfirmed infection, this is really kind of population-based testing. Saliva had 6.8% lower, but again, confidence intervals wide, non-significant sensitivity, the nasopharyngeal swabs. Among people who had previously confirmed infection on nasopharyngeal swab, so after they tested positive, let's say they're in inpatient settings, they're getting tested again to have 2 repeat negatives, saliva was more sensitive, non-significant, by 4.7%. And again, for symptoms and sample collection, this is still fairly consistent. For people symptomatic at the time of testing, about 1,000 samples, 9.7% lower, but non-significant. Among people who are asymptomatic, sensitivity 34% higher. Small number of paired samples compared to the other groups, wide confidence intervals as well. And in cohorts where it was mixed, so another 1,000, sensitivity was higher. Again, non-significant though. So you can see there's a theme throughout here. Saliva collection technique really had minimal impact on overall difference in sensitivity, but appeared most sensitive with an early morning collection technique. At the time of our search, there was no data actually on the swish and gargle approach, but the reports obviously indicate good sensitivity. I'm seeing a chat. I mean, I can't even see the time. I don't know if I'm going way over. There's only a few slides left. Just cut me off if I'm going too long. So we wanted to look at the cost implications of saliva sampling, right? I mean, I'm spouting that there's clearly benefits in terms of materials and human resources, but when we broke it down into their components, the amount of time it takes for a person to collect the sample, the PPE needed, and then the swab and transport needed, media or sterile collection cup, you can see that the costs are a quarter to collect a saliva sample than compared with a nasopharyngeal sample. Okay, so what we wanted to do was conduct an economic evaluation to look at, okay, if we'd replace nasopharyngeal swabs with saliva in COVID-19 assessment centers, what would be the incremental cost per additional infection detected with nasopharyngeal swabs? I'll remind you, in our meta-analysis, it was non-significant, but saliva had a 6.8% lower sensitivity in this population group. So we looked at just assuming that the cost for all other aspects were equal, you still pay the same to transport the sample, you pay the same to have it analyzed, what would be the incremental cost? We accounted for uncertainty by fitting both cost and sensitivity difference parameters to probability distributions and running them, sampling from them 1,000 times. And here's what we found. I'll highlight here, this is the Canadian prevalence right now in people who are showing up to assessment centers. Per 100,000 people sampled, nasopharyngeal swabs cost an additional $630,000. These are, sorry, forgot to note this here. These are in US dollars. So $630,000 US more to sample 100,000 people, per 100,000 people tested with nasopharyngeal versus saliva. Confidence intervals, 470,000 to 830,000. Clearly, there's a big cost implications of continuing with NP swabs. In the analysis, we found that saliva was actually dominant, so it was cheaper than nasopharyngeal swabs and more sensitive, and about 15% of the 1,000 replications we ran. And had a population prevalence of 2.4%, so within assessment centers, the incremental cost per additional infection identified with NP swabs versus saliva was $3,800. If you look at the bottom, highlighted in red, that's the equivalent to the cost of collecting over 1,800 saliva samples, which if you use them, you would have detected 45 infections of that prevalence. So clearly the trade-off here is, I would say, favors saliva sampling, especially at the current positive rate that we're at in Canada. You know, as positive rates increase, obviously our decisions might change. As they decrease, it just makes the argument stronger. Right. So the overall takeaways from here, I'm hoping I've convinced you that active testing of populations can be an important non-pharmaceutical intervention. You might not be convinced it's the most important, but hopefully you see its value, and it can provide critical epidemiologic data and permit further tailoring of mitigation measures. In Canada, implementation of active testing for contacts or surveillance of key populations, I think, is feasible and affordable. But I mean, I didn't get into some of these information system issues, but when we're sending results by fax, I think we, you know, there's some core issues that need to be addressed before we can think about really strong expansion. And then, of course, we still need to leverage human resources, address key bottlenecks and reagents, and we need government commitment to this. And then I think immediately Saliva is the simple solution to addressing certain bottlenecks, can free up trained healthcare professionals where they're desperately needed right now, and can help save money, and should be adopted for sampling in many populations. I just want to thank everybody that I collaborated with, Dick and Tim, for kind of getting this off the ground, and Dick's guidance on this first, this big analysis we did. And there's a large team. I'm not going to go through everyone, but really everyone involved in this first active testing paper, and of course the meta-analysis below, and MI4 for their generous funding. And if you saw some nice graphics, that was courtesy of Danielle Willis at World Bank. All the bad graphics, they were definitely from me. I'll stop here.
Thank you, Jonathan. We'd like to open up the floor to any questions at this time. I know that we have one question in the chat. Did you do any subgroup analyses based on age? Saliva seems like it could be especially useful for kids less uncomfortable than NP swabs.
All right, that's a good question, Emily. We didn't actually have any. We had one pediatric population in our meta-analysis. I don't know if Maya is on the call. Maybe she is. She's the one that would be very comfortable with that data, but we didn't. I don't think there was a large difference, or in any event, there was not enough of a sample size for me to really comment on sensitivity differences based on age here. I see Jesse saying there. I didn't post the. So Jesse's asking about sensitivity differences for early morning saliva samples. I didn't post it. I can share the actual estimate if you want to give me time to pull it up. There was no significant difference, but it was definitely the one with the strongest signal toward favoring saliva. I think the point estimate was 30% higher sensitivity, but the confidence intervals were very wide. It was also the one with the least, I think it was only 3 cohorts included for that.
There was a question that was actually sent to me directly, I think by mistake, from Nazila. Thank you for the great talk. In the first part, you talked about available resources and associated costs in all provinces combined. How was the situation regarding available resources and costs in each province?
Right. So we didn't look at the. So to be clear, we did look at provinces separately and then pooled them at the end. So in our paper here on your screen, and if you want to suffer through 30 some odd pages of appendix, you can see the individual estimates by province. We didn't look at available resources, so what was available in each province at the time. We looked at what was required to get the testing done at each stage of that 6-stage framework. I can't tell you the numbers off the top of my head, but it did vary province to province, of course.
Dr. Susan Bartlett asks, how have public health officials in Montreal and beyond reacted to this information?
Right. So from my own personal communication with the public health officials that we spoke to for this study, very positively, and I'd received an email that they had been implementing kind of this more aggressive contact tracing and testing. There was a little bit of a change in terms of the human resources required. I think at that level, widely embraced. I haven't heard from beyond. I think Dick was the one receiving most of the correspondence from this paper, so he might be better to answer this question. But everyone we had talked to was kind of very excited to help out and participate. And I mean, I think it's a public health, it's a common sentiment in public health to increase testing and the information available to us. I'll let Dick add anything here.
Yeah, just very quickly. I mean, I would say that, you know, we've certainly had some discussions, but there hasn't been much uptake of the, really from provincial or federal.
Right, yeah, at the provincial level, no.
Dr. Dasgupta asks, have you thought about an economic analysis of mandatory quarantine for contacts without testing unless symptomatic?
Right. We had reached out with a modeler in Quebec looking actually at questions like this. So we had thought about it, but we haven't conducted it. And I think there's a good number of modeling studies out now that might not address this exact question, but address similar questions around contacts, quarantine, adherence with isolation, etc., and at least maybe not economically, but at least an impact on epidemic trajectory. Anyways, the person that we'd been speaking to about this sort of modeling in Quebec, we haven't made any headway on, but that was certainly at least a while ago in our plans.
If anyone would like to ask a question directly, feel free. It doesn't have to go in the chat. We have another question from Dr. Dasgupta. Have you thought about sorry, that's the first one. Could you draw on your experience with TB and make some comparison with COVID, examples living with an endemic disease?
Right. That's, I don't know if I'm the best person to answer this because my perspective is I haven't had to live with TB yet. And I haven't had to, I guess, coming from where I am, I haven't had to go through the decisions or the day-to-day of living with an endemic disease. It's a good question. I just don't want to sit on my my podium here and talk like I have the ability to answer it with any strong ability.
Jonathan, maybe I'll just jump in. It's an interesting question. I mean, there are obviously enormous differences. And one of the problems, you know, is that TBs, we've had, you know, over 100 years of experience. And here you have a disease with 6 months of experience, or maybe a bit more now. And a rapidly evolving literature, rapidly evolving knowledge. You know, less than perfect tests at the beginning. That too is evolved. And everybody trying different things. So it's you know, it's a bit chaotic with COVID, I would say. Anyway.
I just want to say out loud, Jonathan and Dick and everyone, this is great work, and we're very proud of CORE, and this is an excellent first talk for our students on stage, and really great turnout, as has been for all of our seminars. So keep it up, guys. Really good.
Last call for questions.
Thanks, Kaberi. I appreciate that.
Dr. Bartlett also says she really enjoyed this presentation and she learned a lot, and thank you.
Thank you. Appreciate the kind comments. Really, it's everyone on the list there on the right and on this slide, and then some. I'm just the one that gets the privilege to present it. It's I'd say I'm just one small cog in the wheel here.
Then I would like to thank everyone for coming. And I remind you that these seminars take place every Wednesday at 4 p.m.